everyone. This is Miss Martha Phillips. She's a clinical pharmacist at Baptist Nassau. She's here today to review some medications that are common for atrial fibrillation. Take it away.
Okay, great. So first thing we'll talk about, I'm sure you've seen like the 12-lead EKG and where it lines up to the action potential of like the cardiac myocytes. So real quick, we'll just kind of go over where the different ions that the medications can inhibit play into this. So on top we have our normal like PQRST, and then down here is the action potential. So it's a 5-phase system. So at phase 0, that's when we have the rapid ventricular depolarization. Then we'll move into phase 1. If you can see it, that's when you get the influx of sodium into the cells, and we'll have our class 1 antiarrhythmics interact right here to block sodium channels. That's one way that we will do that. You move into phase 2 phase 1 where you have your sodium channels closed and the rapid repolarization. And then as that's happening, you move into phase 2 where the potassium is effluxing from the cell and the calcium is coming into the cell. So that's very rapid. Then we'll come down into phase 2, which is like the plateau where the speed is slowing down. And then phase 3 is the rapid ventricular repolarization, where the potassium will leave the cell, and we have another class of antiarrhythmics blocking that. The typical ones that you'll see in that class are amiodarone, dronedarone, sotalol, or ticacin. And then phase 3 is what I just said. Sorry, and then phase 4 is just the atrial repolarization. It kind of starts all over again. So this matches up to the actual EKG. So when we're talking about AFIB and why we're learning about antiarrhythmics, there's two main strategies. So you have your rate control and your rhythm control. Rate control is typically more important is typically more used for people who are like going to be in AFib for a long time. And you'll need your medications to make sure that you're controlling the rate. For outpatients, the typical goal rate is less than 110 beats per minute. That can be changed in the hospital depending on how ill the patient is. Sometimes you might try to do less than 80 or less than 100. And then for rhythm control, that's where we're trying to get back our normal sinus rhythm. So you can do that through like a cardioversion, whether it's going to be like the direct current or a chemical cardioversion with medications like amiodarone. For people who are permanently in AFib, we would not use an antiarrhythmic. It's not going to do anything. And I think that's all I want to say about that. So before we talk about the medications, you want to think about what are your like reversible causes. I know Dr. Mooney put on a talk about AFib recently. So one of the biggest things to think about is your potassium and your magnesium. So always check your labs. If the patient's potassium is less than 4, you're going to want to replete that. If their magnesium is less than 2, replete that as well. And that goes for any type of medication that you're going to be giving them. So first we'll talk about diltiazem. It's a class 4 non-dihydropyridine calcium channel blocker. So that's typically used for rate control in AFib or A-flutter. I don't really talk about A-flutter, but A-flutter is kind of like the teetering point between your body deciding if it wants to be an AFib or if it wants to go back to a normal sinus rhythm. So some of the big things to know about diltiazem, you want to avoid it in heart failure because it can worsen the symptoms. It's a negative enotrope, so it will decrease the heart's ability to pump harder. Our typical dosing that was given usually right off the bat in the ER is a 0.25 milligram per kilogram bolus. You can repeat it again in about 5 or 15 minutes. I forget. I think it's 15. At 0.35 milligrams per kilogram. And if the patient's responding, that's when you'll want to start a drip potentially. So the infusion usually starts at 5 milligrams per hour, and then you can titrate by 2.5 milligrams per hour every 15 minutes. The provider will decide on the heart rate goal, so less than 100, less than 110, depending on what the patient can tolerate. So we are using that to just slow the heart rate down. Here our premixes kind of switch back and forth. Right now we just got our 125 milligram per milliliter premixes back in. Previously we had the hundreds that you have to attach to the Advantage bag, so that's kind of more of a hassle. Moving on to side effects, the biggest one is hypotension. So if the patient is not stable, this is probably not a good option for them if their blood pressure is pretty labile. Other than that, edema, that's a big side effect, a class side effect of calcium channel blockers. And then if you're going to be converting the patient from IV to an oral form of diltiazem, the current rate that the dose is at running is what will determine, there's an equation that will determine the oral dose. So you'll want to give the first oral dose about an hour prior to stopping the drip, so that way it has time to absorb. And then just as a heads up, the duration of the drip, depending on how long it has been running, is from half an hour up to 10 hours. So if the patient's been on it for a while and they're starting to go hypotensive, that could be a sign that you might need to get the drip off sooner rather than later. So that's diltiazem. Next up, we'll do amiodarone. So we mentioned amiodarone works over here. It's a class 3 antiarrhythmic, and it's a potassium channel blocker. Big thing, like I already said, make sure your electrolytes are normalized. It's used for both ventricular and supraventricular arrhythmias. So what's typically given is an IV bolus of 150 milligrams over 10 minutes. And then you'll move on to the loading dose of 1 milligram per minute for 6 hours, and then half a milligram per hour for 18 hours. And the whole goal of this is if the patient's going to be chemically cardioverted, you'll need to get them up to 10 grams of amiodarone before they can be decreased on their dose. So if the patient's going to be discharging on amiodarone, it is normal to have both oral and IV given at the same time to get to those 10 grams. Amiodarone has a super long half-life, so it's not very easy to turn off. One dose can be in the body for 58 days. It does have a black box warning for pulmonary and liver toxicity. So some of the common side effects of this one, hypotension and bradycardia, but not as much as diltiazem. And then photosensitivity, it can cause like a rash, and some people have been taking it a long time. They can see different discolorations in their eyes, neurotoxicity. But when the patient's just starting on it, you wouldn't really expect it because it hasn't accumulated very much. This one has a whole bunch of interactions, specifically like warfarin, digoxin, all the statins. So amiodarone can increase the concentration of those medications. So that's something to take into consideration for a patient being discharged, so some of the counseling for that. Warfarin's a pretty important one in this case because if a patient needs to be anticoagulated for their AFIB, you'll have to adjust their warfarin dosing accordingly. So I have the amiodarone tubing that we need to use. It's the green Alaris pump with the 0.2 micron filter. It's low sorbing. So hopefully if the patient has a central line, you can give it through the central line. If not, that's fine for a couple days, usually max of 2. But you need the low sorb DEHP free tubing with the filter. And Teresa confirmed it is in the med room here. For the bolus, since the bolus is given over 10 minutes, you don't necessarily need to give the low sorb tubing. And then another big thing with the amiodarone is to watch out for other QTC prolonging medications. So you know the QTC, or the QT is up here, so the Q to the T, that can get wider. So that's typically a concern when a patient's on maybe like 2 or 3 of these medications, like maybe the patient's on amiodarone and they're getting Zofran, and then they need to start an antibiotic like azithromycin. You'll want to check their EKG to make sure that their QTC interval is not over 500 milliseconds. Other medications that can interact are all of the antipsychotics pretty much. Fluoroquinolones, so like the Cipro and the levofloxacin. The azole antifungals like fluconazole, and a lot of HIV medications, which we don't typically have our patients on here. How's my time? Good? Okay.
Yes.
So next we'll talk about the beta blockers, specifically esmolol. So esmolol is a class 2 antiarrhythmic. It's just blocking beta blocker. So you typically use it for AFib or A-flutter for rate control. One big thing to know about this is to avoid it in decompensated heart failure. So our typical dose for esmolol is 500, if you're going to be starting them on an infusion, is 500 microgram per kilogram bolus. So if you're a 70 kilogram person, that's like about 35 milligrams. And then you do 50 micrograms per kilogram per minute and you may need to bolus them again, but then the max rate would be 200 micrograms per kilogram per minute as an infusion. The biggest adverse effect of this one, similar to diltiazem, is the hypotension. So if a patient is not stable and their blood pressure is going all over the place, you would not want to use this. And another thing that's a class effect of beta blockers is careful if the patient has like a bronchospastic disease like asthma or COPD, it can worsen that. So one reason why you might want to use esmolol is it has a really quick on and off action. So it lasts about 2 to 10 minutes. So if the patient does go hypotensive, you can turn it off pretty quick, and it has a 9-minute half-life. At Baptist, esmolol is reserved to ICU and ER status only. Another option would be IV metoprolol, which you would give every 6 hours to see if the patient is being controlled appropriately, and then you can convert them over to an oral option. One nice thing about giving IV pushes instead of a drip would be if the patient is hypotensive, you wouldn't have to give them that next dose as it's scheduled. Okay. I think the last medication that we'll talk about is digoxin. So digoxin is mostly for rate control. It inhibits the sodium, potassium, ATPase pump. So basically what it does is it has a positive inotropic effect on the heart, so it makes the heart beat harder, but it has a negative chronotropic effect, so it makes the heart also beat slower, so slower and harder. It can be used in both AFIB and heart failure, so this is good. This is a good option if the patient is a heart failure patient. So typically what we would do is if a patient's going to need to be put on digoxin because it takes such a long time to get to like a normal therapeutic level, they may do like loading doses. So you would give those IV push over 5 minutes every couple hours until that gets them up there. The only reason is just to get them to the steady state level quicker in the therapeutic level. It doesn't really have much of an effect on blood pressure, so that's a good option, like I said, for people who may be unstable. Patient considerations, you may want to start at a lower dose in patients who are older, lower body weight, have poor renal function. Those are all reasons that the digoxin could accumulate in the body and cause issues. Always make sure, like we said, potassium greater than 4, magnesium greater than 2. Especially with digoxin, this can increase the risk for toxicity of the digoxin. Digoxin is a vesicant, so that's why you want to make sure that if you're going to push it, it goes up through slowly. Make sure the vein is positioned, or the catheter is positioned correctly. You can dilute it if you want to. And then for patients who come into the ER from a digoxin overdose, where their level is much too high, we do have the antidote here, which is DigiFab. So some nursing considerations, like we said, really long half-life, takes weeks to get to steady state if you're not going to load them. Some side effects would be blurry vision, double vision, green-yellow halos. So if you ever heard that fun fact about Van Gogh, he was treated for his seizures with digoxin. That's why he had these like green-blue halos in the Starry Night, and that's kind of like why they said that he like painted like that. So that's a sign of toxicity. Digoxin's not for seizures, and that can also decrease your heart rate. There are a lot of interactions with this one. So like we said, the warfarin, amiodarone, anything that can cause QTc prolongation. And then for another Baptist consideration here is we have a standard admin time for the oral tablets of 1400 or 2 o'clock, because we want to make sure that the effect of that digoxin is not being, like whatever happens to the body can be attributed back to the digoxin versus something from their morning meds. When you're drawing levels, make sure you draw it 12 to 24 hours after the dose. That also is part of the reason why we have the standard admin time of 1400, so that if it's drawn with AM labs, it can be used. And then the therapeutic level for that is 0.8 to 2 for AFib. It's a little bit lower for heart failure. And then the last thing I want to say about digoxin, the IV form, it comes in the ampule. The ampule is glass. So when you break it, little bits of glass can go into the vial. So you have to use a filter needle to draw it up. We think it's like a brown gray color. I think they're all this color, so you have to use a filter needle. And I think that's it. Teresa, did I forget anything?
No, you didn't. You did a phenomenal job. We
Thank
want to
you.
thank you so much for this.
Yeah.
And hopefully you can keep keep a slot open for us in the future for some other things that we want to go over. Thank you again.
Absolutely, yes.
Yes,
Thanks,
you did a
Ashley,
great
for
job.
filming.